The classification described by Bingley group from China, they are divided into 3 subtypes. ARID1A subtype, they have a good prognosis, usually predominantly located in the antrum. They have better survival and they are more sensitive to chemotherapy. They correspond to other classifications of MSI and EBV. They have epithelial phenotype. The second one is the T50, TP53 negative type. They are resistant to chemotherapy. They have poor survival. They are correlate with the CIN variety of the TCGA classification. CDH one type, they are also resistant to chemotherapy. They have poor survival. So they correlate with the genomically stable variety of the TCGA classification. So this is another classification divided into 6 subtypes. EBV, DMMR, EMT, chromosomal instability, genomically stable and not otherwise specified varieties. So the EMT variety is more aggressive and EBV and DMM are less aggressive and the other 2 are intermediate prognosis. So other classification is Singapore Duke classification divided into mesenchymal, proliferative and metabolic varieties. The proliferative and metabolic varieties have intestinal histology and mesenchymal variety has a diffuse histology. The proliferative variety has a worse disease-free survival and metabolic they are more sensitive to 5-FU. So this is one study where they have 500 plus patients. So they have shown a Kaplan-Meier curve of 5-year survival stratified by molecular subgroups of TCGA classification. So in all patients, the p-value is not significant here. So the 5-year survival is not significant. In intestinal type of tumors, also it is not significant. But in diffuse type of tumors, it is significant with good prognosis for EBV and bad prognosis for MSI tumors. So again, all patients with tumor radical resection, here also it is not significant, the survival between the different molecular groups. Here also, intestinal type tumor with radical resection, it is not significant. But in diffuse type of tumors with radical resection, again, it is significant. So NCCN guidelines for advanced gastric cancer also includes the study of different molecular markers, IHC, MSI, TMBH and NTRK gene fusions. So these are the different molecular targets in gastric cancer, targeting differential gene expression, gene mutations, DNA and histone methylations and somatic copy number alterations. So these are the targets and the therapeutic agents in the gastric cancer with relevant studies. The different targets being HER2, VEGF, EGFR, FGFR2, PI3K, AKT, mTOR and MET with different therapeutic agents. So immunotherapy and target therapy in metastatic gastric cancer by monoclonal antibodies with different targeting agents also we can target. And also target therapies in metastatic gastric cancer with the different studies mentioned here. And checkpoint inhibitor therapies in metastatic gastric cancer with the different trials. So to summarize the topic, the current systems of classifications are insufficient guide for personalized treatment of gastric cancer. Gastric cancer being heterogeneous and multifactorial disease which is influenced by both genetic and environmental factors. The recurrence rates of gastric cancer remain high in stages 2 to 4. The one size fits all approach is not suitable for all varieties of gastric cancer. And the TCGA and ACRG are widely accepted classifications of gastric cancer. The molecular classification transforms the management of gastric cancer by enabling better prognostication, tailored treatment strategies and identification of novel therapeutic agents. The limitations being limited biomarker drug matches and varying access to the testing. These are the articles which I have used for my search. Recent articles, majority of them are. Thank you.